All right, everybody, welcome. My name is Kelly, and I work with the Alberta SPOR Support Unit Career Development Platform. Before we get started, I'd like to acknowledge that although we are meeting virtually, each of us live on the traditional lands of First Nation, Métis, and Inuit people, whose histories, languages, and cultures continue to influence and enrich our vibrant community. I'm pleased to welcome you to this session today, where the Alberta SPOR Studentship Awardees will present their exciting research projects. This is part one, and we will have 6 students presenting today and more on Tuesday of next week. But before we get started, just a few words of housekeeping. This session is best viewed in speaker view, not gallery view. Please keep your video camera off during the session to ensure your privacy and to prevent interference with your audio. If you'd like to access the reaction buttons, such as thumbs up, you can click on participants at the bottom of the live stream window. And then you should see the reaction icons at the bottom of the participants tab. If you have any questions, please post them in the session Q&A box in Whova or in the chat box in Whova, or you can also post them in the Zoom chat box as well. And we have Christine here from our team to help with moderating the questions. If you experience any technical difficulties, the best first step is to exit and then rejoin this session. And then you could also post questions in the chat box in Whova or in Zoom for technical help from our team. This session is being recorded in Whova, and you'll be able to watch the recording later when it gets posted in Whova. So for the session today, each of the students will present for 5 minutes, and that will be followed by a 5-minute question period between each student presentations. So I'd like to introduce our first presenter today, Pamela Klassen, who is presenting on the evaluation of pancreatic enzyme replacement therapy to optimize nutrition and address patient priorities in advanced cancer, pancreatic cancer. Pamela is a master's student in nutrition and metabolism at the University of Alberta in the Department of Agriculture, Food and Nutritional Sciences. So Pamela, take it away.
Hey, thank you so much for the introduction. It's great to be here, and thank you everybody for attending. I'm going to just leave my video off because you're looking at the poster anyway, but I wanted to say hi first. So if I move my screen like this, Kelly, can you just confirm that it actually gets bigger for you guys too?
Yes, it did get bigger for me.
Okay, perfect. Great, so we'll get started. So yes, I have a background in nutrition and dietetics. I worked as a dietitian for 13 years before coming back to grad school. And particularly, I worked with cancer patients. So pancreatic cancer is close to my heart and practice area. If you have someone in your life or friend group who's had a pancreatic cancer diagnosis, you know that the prognosis is devastating. The majority of tumors are not removable, and so therefore it's palliative treatment only. And in this case, palliative chemotherapy is provided or offered to control the disease symptoms and extend survival time if possible. But malnutrition is a major complication of pancreatic cancer, and it stands in the way of these goals of therapy. The hallmark or the key indicator of cancer-associated malnutrition is a rapid loss of skeletal muscle. One of the causes of this malnutrition is this reduced digestion and absorption, and that's because the pancreas is basically the heart of the digestive system. And in pancreatic cancer, the pancreas is unable to produce enough enzymes to digest the food that patients take in, and that also blocks absorption. Or there's actually a blockage in the enzyme delivery system. So not only does this pancreatic enzyme insufficiency lead to malnutrition, it also contributes to very high symptom burden and very poor quality of life. In a study by Gooden et al., it was found that the gastrointestinal symptoms of pancreatic cancer were actually the most significant unaddressed concern for patients and their families. So oral enzyme replacement therapy or oral enzyme capsules has been suggested to treat enzyme insufficiency in this disease. And it was actually instituted as part of the standard of care for unresectable pancreatic cancer in 2018 at the Cross Cancer Institute here in Edmonton. But it's not a practice that's been consistently implemented across Canada because we lack strong evidence for its benefit in this disease. So to that end, my study aims to evaluate the effective enzyme replacement therapy on clinical outcomes, including skeletal muscle, that's our marker of nutrition status, and on overall survival, and also on patient-reported outcomes, because we know that in palliative disease or end-stage disease, we're not just looking at overall survival, we're looking at patient experience and quality of life. The second aim of my study is to explore the relationship between skeletal muscle parameters and patient-reported physical function. So the study has two phases. The first phase is going to use a case matching approach to compare patients who did and did not receive enzyme replacement as part of their standard of care, because I mentioned those two groups of people at the Cross Cancer. Prior to 2018, they did not receive enzymes, and after 2018, the majority of them did. So using this matched cohort groups, we'll compare the differences in their rate of skeletal muscle loss over time, over 6 months, and compare their overall survival. So I'll just draw your attention to this picture in the middle. Skeletal muscle loss in oncology patients is assessed using existing or standard of care CT scans. So patients have these at diagnosis and then every 8 to 12 weeks while they're on treatment. Skeletal muscle is defined in red. It's measured in area or cross-sectional area in centimeters squared. The muscle at the lumbar, the third lumbar vertebrae, which is the sort of mid-slice of the body, correlates very well with total body muscle. So using these CTs over time, we can accurately calculate the rate of skeletal muscle loss with really no additional patient burden because they're having these scans anyway. But a retrospective study of skeletal muscle change does not help us describe the patient experience. The second phase of the study will enroll newly diagnosed patients and have them complete patient-reported outcome measures prior to initiating enzyme replacement therapy. And we want to assess their physical function from their perspective, digestive symptoms, and their quality of life. We'll then repeat these measures at each CT scan up until 6 months. So for most patients, that's 12 weeks and 24, and some might have some CT scans in the middle there. So from this data, we'll be able to see the change in symptoms and quality of life before and after enzyme initiation. And we'll also be able to explore any relationship between those skeletal muscle measures and the patient-reported physical function. Now, this study, this prospective study, is in the design phase, and we are seeking additional patient partners with experience of pancreatic cancer to help us design and implement this study. So if you know anybody with pancreatic cancer, get them in touch with me or somebody who's experienced it with a family member. My hope is that this study will result in some real-world evidence to help us know whether or when to prescribe these enzymes to patients, and certainly to give us another strategy or evidence for a strategy to slow the progression of malnutrition and improve the quality of life for patients with pancreatic cancer. So stay tuned for the results. I do want to acknowledge the support of the Alberta SPOR Graduate Studentship and a Canada Graduate Scholarship, as well as my supervisor, Dr. Vera Mazurek, and all of the SPOR experts that I've learned from over this past year. So thank you very much for your attention, and I'm happy to take any questions.
Thanks, Pamela. There's a couple of questions here. First is, how are you working around the COVID-19 pandemic in your project?
Right. So this was, the retrospective study was birthed in COVID-19, and really because at that point we have this data already. It's in the clinical record, and that's why we're using those clinical outcome measures. The prospective study is being done in partnership with the Pancreatic Cancer Clinic at the Cross Cancer. And so the dietitian that's there is already seeing patients, and she's actually the point of recruitment for the prospective study. My patient partner meetings to date have all been virtual and will continue to do that. And then because these are patient-reported outcome measures, they're already validated tools, and we can send them directly to patients via REDCap. So again, that can be virtual too. There's no requirement for an in-person visit with the patient aside from what they're already doing clinically.
Thank you. One more question. How did you determine that this study was valuable to patients?
Well, like I mentioned, the study by Gooden really showed that was a study of the psychosocial unmet needs of patients, and what emerged was really an unmet nutritional need, really the management of those gastrointestinal symptoms. So that was my first clue. Second was that I've worked with pancreatic cancer patients for 5 years. So I have done a lot of listening in terms of what they need. And then lastly, I think the patient partners in the prospective study, the goal of engaging them is to have them help us identify any other priorities and also confirm that these are priorities for them. I think, and then also the dietitian and the oncologist at the clinic would both echo that the symptoms of this enzyme insufficiency is a really high priority for patients. Physical function is less well defined as a priority, but there definitely is a study, or I referenced a study by Friel there that said patients at the end stage of disease will, 80% of cancer patients at end stage disease preferred or prioritized physical function over extended survival. So that was my first clue to why I included physical function here.
Thank you. That was our last question, I think.
Okay.
Actually, I think I did see one final question in the chat box. Someone is wondering if you try enzyme therapy with other cancers.
We don't use it with any other cancers, mainly because the pancreatic cancer is one of the only ones that would interfere with enzyme production. It's used in other diseases like cystic fibrosis and chronic pancreatitis. And that's where the idea came to start using it in pancreatic cancer.
Perfect. Thank you very much, Pamela, for a wonderful presentation. Now I will turn to our next presenter, Alyson Kwok, who is doing a master's in rehabilitation science in the Faculty of Rehabilitation Medicine at the University of Alberta. And the title of Alyson's presentation is Maximizing Patient Engagement. Maximizing patient engagement through collaborative outcome measure selection and tracking. So Alyson, take it away.
All right, just a second. Maybe I'll turn on my video before I keep sharing my screen so I can do a similar introduction. So I'm very excited to be here presenting my poster. My name's Alyson. I'm actually a physical therapist, and I've worked with stroke patients for over 15 years. And I've decided now to go back to school, and it's been really exciting to be a part of this SPOR studentship. I've had a lot of support. So I'll quickly walk through my poster here. After working with patients for so long, I started to notice that a lot of our therapy time is sometimes spent collecting outcome measures. So we know that after a person has had a stroke, their time spent with their physical therapist is really precious. We want to make sure that we're maximizing every minute. And it started to lead me to question whether that is always the best time spent. There's been an increase in the literature around best practices with outcome measures, but I've noticed that it is very therapist or facility centric. It doesn't really focus on what patients want or find valuable. And we know with a patient-oriented approach to healthcare, we really need to be thinking about what's valuable to patients. In addition, I'm really excited about the concept of patient engagement. So how can we make the most of our time with patients to make sure they're doing everything they can to support their own health and to hopefully even carry on beyond the physical therapist-patient interaction to continue to support improvements in the future. So Trish, my supervisor, and I were excited a few years ago to stumble across a really interesting study that showed that reporting an outcome, a specific outcome measure on gait speed, resulted in improvements compared to the control group who didn't know how fast they walked each day. And we started to wonder if actually involving patients in the tracking of outcome measures could support their, not only their engagement in therapy, but maybe their outcomes as well. So we thought that the first step was actually to go back and start to gather some opinions from patients. So this particular study is going to be a qualitative case study. We're looking at an inpatient rehabilitation facility as our case. I'll be doing observation, chart review, patient interviews, therapist interviews, just trying to gather information on what patients think about these outcome measures, which measures are most valuable, what processes help to support engagement, etc. I will be also bringing all of the participants back for a final focus group where we'll start to develop recommendations together. The most exciting part of this so far has been involving 3 patient partners. So I have 3 very, very interesting, very dynamic patients who have experienced moderate to severe stroke and are now working with me to help develop this study. We meet regularly via Zoom. I wasn't really sure where to even start until I started with SPOR. They really supported me to figure out how to engage these patient partners. And so it has been a wonderful experience. They've helped shape my research already, and they'll be guiding the whole process. We're hoping at the end we'll have a set of recommendations that can actually influence practice change, but also with the rollout of Connect Care and the potential for patients to perhaps have more ability to see their own outcomes through their devices. We are hoping that our recommendations could even influence builds in Connect Care. That's the summary of my poster.
Thank you, Alyson. I'm going to ask the same question to you as I started with Pamela. So how has the COVID-19 pandemic impacted your research?
Well, the biggest change so far is that when I started meeting with the patient partners, we couldn't meet in person. So we've had to have all of our meetings over Zoom. I haven't started my data collection yet, but I am making plans to start. And there's several procedures in place that I have to follow. So I'll be giving all of my patients the opportunity to conduct their interviews over Zoom or over the telephone if they prefer. But if I do go in person, I have to follow all the hospital protocols. So masking and keeping distance and things like that.
Great, thank you. We also have a question over on Whova, and it says, have you looked into zoeinsights.com? Patients can identify an outcome and monitor it, and it can be shared with physicians.
No, that sounds wonderful. I will take a look at that.
I think that's all of our questions for you. I know that was really quick, but thank you.
No problem.
Great, thank you so much, Alyson. That was a wonderful presentation. I'll move on to our next presenter, who is Anika Sehgal, who is doing a PhD in Health Services Research in the Community Health Sciences at the University of Calgary. Anika will be presenting on complexity among Indigenous patients, developing a patient complexity assessment tool to identify and address the determinants of health impacting Indigenous peoples in Canada. So Anika, go ahead and take it away.
Hi, can everyone see my screen?
I can see your screen.
Oh, perfect. Thank you. Thank you for that wonderful introduction. So yes, my project is looking at complexity among Indigenous patients. So I'll just start by giving a bit of background information. We know that there are significant health disparities between Indigenous and non-Indigenous people that exist today, rooted in social, political, and economic inequalities due to historical and ongoing injustices. So in 2015, the Truth and Reconciliation Commission outlined 94 calls to action, and several of these actually called upon the healthcare sector for reform. So in my study, I'll be looking specifically at call number 20, which states that in order to address the jurisdictional disputes concerning Indigenous people who do not reside on reserves, we call on the federal government to recognize, respect, and address the distinct health needs of Métis, Inuit, and off-reserve Indigenous peoples. So what is patient complexity? While in clinical settings, Indigenous patients often present with complexity, which is defined as the interaction between personal, social, and clinical aspects of the patient's experience that can complicate care. Having patient complexity assessment tools is one way that healthcare providers can better identify the needs of the patient and in turn improve health outcomes. But there's a major gap that exists today in that there's no tool that addresses the Indigenous conceptualizations of health and wellness or the determinants of health that uniquely impact Indigenous people. So for Indigenous people, health often exceeds just the biomedical aspects and includes broader components such as a sense of belonging to family and community. And wellness is actually a state that is achieved by balancing physical, mental, emotional, and spiritual elements. The determinants of health for Indigenous people often include things such as social exclusion circumstances, ongoing colonialism, and intergenerational trauma. So there's no such tool that addresses all of these things. The aim of my research then is to develop this patient complexity assessment tool grounded on the Indigenous conceptualizations of health, wellness, and its determinants so that healthcare providers can better understand the realities of health for their Indigenous patients. Now, I've divided this research up into 4 main objectives here, but essentially I'll start by identifying the determinants of health that are already acknowledged in pre-existing patient complexity assessment tools. I'll then work to explore the Indigenous conceptualizations of health, wellness, and its determinants. Then I will understand from Indigenous patients themselves and their experiences the factors that cause complexity. And finally, I'll use an iterative item development approach with subject matter experts to develop this patient complexity assessment tool. Now, in terms of the item development approach, I'll start by developing a conceptual model. I'll then develop a candidate item pool using existing complexity assessment tools. And then I'll generate new items that address the Indigenous conceptualizations of health, wellness, and its determinants, and also new items based on the lived experiences of Indigenous patients themselves. And then I'll be employing a modified Delphi method with subject matter experts to refine all of these items and finalize the ones to be used in this proposed tool. Now, my research here is aligned with both Western and Indigenous methodologies so that it engages this concept of an ethical space. I'm using a very Western approach to scale development, but that's because I want this tool to be employed within the current and inherently Western structures of healthcare. But the foundation of this scale is based on a need within the Indigenous community to better understand patient complexity among Indigenous people. And the inherent underlying purpose of this tool is to resist the colonial impacts of current frameworks of healthcare. Therefore, I'm engaging both Indigenous and Western knowledge spheres and the overlap between these knowledge spheres. Finally, I would just like to conclude and say thank you for choosing me to be one of the 2019 Alberta SPOR graduate studentship recipients.
Thanks, Anika. You can probably guess which question I'm going to ask first. How has the COVID-19 pandemic impacted your research?
Yeah, so I'm not at the stage of data collection yet, but I've definitely been thinking about how I would engage Indigenous patients if I'm not able to meet with them in person because of COVID-19. And I think that it's more difficult to just sort of say that I would meet with them via Zoom or phone call when a lot of these resources sometimes are not available for Indigenous patients. So it's been challenging for sure to identify the pathways that would be best appropriate to reach Indigenous patients in a COVID-19 climate.
Thank you. The other question is, will you be presenting the results to members of the Indigenous community?
Yes, that's correct. I will be presenting the results to members of Indigenous community, which is part of my knowledge translation plan, and also being respectful of using Indigenous methodologies and engaging Indigenous patients.
Will you ask them to review your tool before it's finalized?
Yes, I will be asking. This tool is going to go through several stages of refinement, but the end goal for the purposes of my degree is to fully develop it. And then after that, we will be doing the pilot testing, reviewing validity to really refine it and make sure that it's appropriate.
And last but not least, this is also a duplicate question, but how did you determine that the study was valuable to patients?
Well, we see that in clinical settings, Indigenous patients are often deemed complex, and there is healthcare providers often do want to help, but they just don't know how. So there's a need to identify better pathways to address the needs of Indigenous patients. And I think that this tool is essentially a framework that will help healthcare providers better understand what is needed for Indigenous patients and what they can do to help.
Thanks. Just a reminder to everyone else here, if you have questions as we go along, you can ask them in the chat box here in the Zoom room or on Whova.
That's great. Thanks very much, Christine. Someone has just sent me a question privately in the chat, so I'll just read it now for Anika. How has cultural humility factored into all stages of the study design, particularly for those gathering the data in the field?
Thank you. That's a good question. So I think just the concept, by engaging the concept of an ethical space, we're really taking into account the idea of cultural humility. And this is why I'm not using an exclusively Western approach to scale development. And I've chosen to engage both Western and Indigenous research methods and Indigenous ways of knowing to ensure that we are being culturally appropriate and culturally humility.
That's great. Thanks so much for that, Anika. And thank you for your wonderful presentation. We'll move on to our next presenter, Adrijana D'Silva, who is a PhD student in community health sciences at the Cummings School of Medicine at the University of Calgary. And her presentation today is on meditation and yoga for irritable bowel syndrome, the MY-IBS study. So take it away, Adrijana.
Great, thank you. I'll just take a moment here to share my screen with you. Perfect. First of all, thank you very much for the opportunity to present today, and thank you to everyone who's in attendance. I would like to share with you my proposed work for my PhD research entitled MY-IBS study. So first of all, I want to introduce irritable bowel syndrome, or IBS, which is a chronic disease, and it has a considerable burden on both the individual and the healthcare costs in our society, because it affects anywhere from 12 to 20% of the Canadian population, depending on how it has been assessed. There's a connection between the gut function stress and the psychological processes that have been demonstrated in IBS pathophysiology, and therefore therapies that are focused on the mind-body interactions and stress reduction may be useful adjunctive treatments for IBS. What we know currently from the literature is that yoga is effective and safe, and this is based on 4 randomized controlled trials, and that it potentially may target multiple mechanisms that are involved in the treatment of IBS mechanisms. So in terms of aims, they are to explore the feasibility of implementing a yoga program for patients with IBS, and this will be achieved through an assessment of implementation needs with both patients and gastroenterologists, but also an evaluation phase of feasibility and effectiveness in a trial. So this study has been divided into 3 sub-studies or 3 phases. And our first study is to identify gastroenterologists' attitudes, supports, barriers, facilitators, and their intention to recommend a yoga program as a part of routine medical care for their patients with IBS. So we will be recruiting 80 practicing gastroenterologists across Canada who have provided care to adult patients with IBS. We will ask them to complete an online survey, and this will examine their demographics as well as attitudes and beliefs about yoga and online delivery using a 7-point Likert scale. So they can tell us anywhere from their strong disagreement or strong agreement on a particular statement. We'll also inquire about their current referral practices, if any, what their perceived supports for recommending yoga is, any barriers and facilitators, and what their intentions are to recommend yoga for IBS in their clinical practice. We're hoping to gather outcomes on attitudes, perceived supports, barriers and facilitators, and intentions that would either limit or promote the implementation of an online yoga program into routine medical care for IBS. Our second study is focused on the patient. Here we would like to identify their attitudes, perceived support mechanisms, as well as facilitators, barriers, preferences, and past experiences with yoga, if any. So we are hoping to recruit 109 IBS patients from a variety of sources, mainly from GI clinics across Calgary, the Imagine cohort study, the primary care networks in Calgary and area, and several private IBS Facebook groups. We will be looking to recruit adults who have been diagnosed with IBS based on the most recent Rome 4 criteria and who also have the ability to communicate in English and take our survey. The survey will be done online as same as platform in REDCap as the gastroenterologist survey, and will be developed on previously completed literature review and using the theory of planned behavior standardized questions that are used to elicit responses. We will also pilot test this survey with a small sample of reviewers, including gastroenterologists, but also with patient representatives. We're hoping to gather attitudes towards yoga, people who perceive who would help them or not support them in participating in a yoga program, and how barriers and facilitators influence their intention to practice daily yoga. In addition, we would also like to know any previous and current experiences they may have with yoga, as well as preferences on delivery modality. So we would like to know if they prefer to have face-to-face contact or if they are comfortable in an online setting. Our third study will be looking at examining the feasibility, just a moment here, feasibility and effectiveness of a daily 8-week live online facilitator-led yoga and meditation program, and comparing that to an online self-directed delivery in a randomized controlled trial. In terms of recruitment for our participants, we'll use the same criteria as outlined in study 2, but we will also like to see if any of our survey participants in study 2 would be interested in participating in future research such as this trial. We would like to exclude any individuals who have any physical impairments that could prevent them from participating in our yoga program, as well as any major cognitive, psychological, or psychiatric disorder, either as identified by their treating physician or healthcare practitioner or screened by the study coordinator. The intervention itself will have 20 participants per group. Group 1 will receive education about factors contributing to IBS development and severity and how yoga may be used as a therapy. The same educational component will be presented to group 2, and both groups will receive a Hatha yoga intervention delivered by a trained yoga facilitator from the Isha Yoga Institute of Inner Sciences. In terms of outcomes, the primary effectiveness outcome in this study is the IBS symptom severity scale, and we have several secondary effectiveness outcomes, including the IBS quality of life, anxiety and depression, perceived stress, fatigue, severity of somatic symptoms, and microbiome composition as well. Just recently, we have decided to include a COVID measure. So there has been a recently validated COVID stress and anxiety scale that we would like to include and assess as well. These effectiveness outcome measures will be assessed at baseline 4 and 8 weeks within and between groups. We will also look at feasibility, and these outcomes would include recruitment and retention rates, adherence, program preferences and satisfaction, as well as adverse event outcomes. We're hoping that the findings from this study have important implications for the management of IBS, as online yoga may be used as a flexible and low-cost adjunct therapy to improve both physical and mental health outcomes with patients and patients with IBS. Thank you.
Thank you, Adriana. I feel like you got ahead of my first question, but I'm going to ask it again. So how has COVID-19 pandemic impacted your research?
Yes, absolutely. So with our first 2 studies, because they were originally set up to be online surveys, we actually haven't experienced any difficulties. For a bit there, we didn't have a lot of recruitment come in from our gastroenterologist survey, just because back in March and April, a lot of these clinicians were scrambling on how to adjust to their clinic practice and how to help in the front lines during COVID times. However, in terms of study 3, we've had some setbacks. Initially, the study was looking to compare online delivery versus face-to-face, which is quite traditional in this field. And we had to pivot quite a bit. And now our study design includes and compares 2 online delivery methods, just one that is self-directed and one that is facilitator-led. Also, our patient partner meetings, as mentioned earlier by some of the other presenters, were thankfully in person at the very beginning. So we were able to establish a bit of a relationship there, but now they've all moved online as well.
Thanks. There's another question here. In study 2, do you define yoga as an exercise strategy or as a spiritual practice or both?
I would like to define it as both, and mainly because the intervention that we are using here has both components. So we include several postures in the intervention, but we also focus on meditation, breath watching, as well as chanting.
That's perfect. Thank you, Adriana. And I have one question here in the Zoom chat. Great presentation, Adriana. I'm wondering if and how you are considering the traditional historical roots of yoga in your study design.
That is a very good question. Thank you. The type of Hatha yoga that we decided to go with is Upa yoga, and it comes from one of the disciplines of Hatha yoga that was developed many years ago in ancient India. And in terms of the ancient teachings, some of the components in the meditation and how that may affect the human body, mind, and spirit are also incorporated into the teachings that this intervention has.
All right, that's fantastic. Thank you so much, Adriana, for a wonderful presentation.
Thank you.
I'll move on to our next presenter, Kelsey Ellis, who is a master's student in the Faculty of Kinesiology at the University of Calgary. And Kelsey will be presenting today on yoga for pediatric patients and survivors of oncological and hematological diseases. Kelsey, I'll turn it over to you. Take it away.
Great, thank you. I'm just going to share my screen here. All right. Hello, everyone. My name is Kelsey Ellis, and I am a second-year master's student in the Health and Wellness Lab at the University of Calgary. I'm working under the supervision of Dr. Nicole Kulas-Reed. and today I will be presenting my master's thesis titled Yoga for Pediatric Patients and Survivors of Oncological and Hematological Diseases. Children and adolescents diagnosed with oncological and hematological diseases face negative symptoms and side effects associated with their disease and intensive treatments they receive. Research in this population has showed that yoga may mitigate negative disease and treatment-related effects, as well as enhance physical and psychosocial well-being. Summarizing this literature to identify strengths and areas for next steps is critical. In addition, the perspectives of yoga instructors, a key stakeholder group who deliver the yoga programs for this population, has not yet been examined. Therefore, the purpose of my MSc research is twofold: to systematically review the literature reporting on the effects of yoga for youth with oncological and hematological diseases, and to use qualitative inquiry to explore yoga instructors' training requirements, experiences, and perspectives with yoga programs for youth with oncological or hematological diseases. This systematic review is currently underway and includes articles of any study design, reporting on the effects of a yoga intervention with individuals aged 0 to 18 years with a current or past oncological or hematological diagnosis. No comparator outcomes are specified in order to collate all of the existing literature examining the effects of yoga for these populations. As mentioned, this research is currently underway. To date, we have developed a systematic search strategy based on relevant literature, content, expert input, and guidance from a librarian. For the search strategy, we have included 8 databases, including Medline, MBase, Sport Discuss, Cumulative Index to Nursing and Allied Health Literature, Cochrane Database for Reviews and Control Trials, Scopus, and Alt Health Watch. We are using tested search strategies covering keywords surrounding yoga, children, and oncology hematology. These searches were conducted in August 2020 and will be rerun before our final analyses. So far, 3,915 citations have been screened at the title and abstract level, and 2 independent researchers are currently screening 84 full-text citations. Once full-text screening is complete, 2 reviewers, including myself, will independently extract the data and assess risk of bias and study quality of included studies via the Cochrane collaboration tool for randomized control trials and the risk of bias assessment tool for non-randomized studies. Discrepancies in scoring will be resolved via discussion with a 3rd reviewer, and results will be summarized via narrative synthesis and will be presented to key stakeholders, including yoga instructors and patients and families, to review the results. For the qualitative study, we are currently conducting semi-structured interviews to explore yoga instructor perspectives of program delivery, training requirements, and yoga program or intervention experiences. We have 8 yoga instructor interviews completed to date with a range of pediatric oncology yoga experience. 2 more interviews have been scheduled and recruitment is ongoing through Dr. Koulos Reed's programs of research, social media platforms, membership directories, and snowball sampling. We hope to recruit 5 to 10 more yoga instructors for this study. Interviews are audio recorded, transcribed verbatim, and will be analyzed using principles of thematic analysis and interpretive description. We will identify and compare themes using a constructivist framework based on instructor experiences, delivering programs with diverse pediatric oncology populations, including populations on and off treatment for different types of cancer and blood disease, and for various age groups, as well as perspectives of yoga instructors in diverse settings, including in-hospital, community-based, and virtual settings. This work embodies a patient-oriented research approach and aims to improve patient outcomes. We have included key stakeholder voices as part of the review process to reveal what is important to them based on the research completed to date, as well as to identify gaps of needs for future work. The interviews with yoga instructors will be instrumental in identifying training needs, logistics for programming, and considerations for implementation. Collectively, this work will inform evidence-based yoga programs for youth with oncological and hematological diseases. I would like to take the time to thank and acknowledge the Alberta SPOR Support Unit for their support in funding my project, as well as my supervisor, Dr. Nicole Koulos-Reed, for all of her help and support so far, and my committee members, Dr. Amanda Wers, Dr. Fiona Schulte, and Dr. Lillian Sun. Thank you all for listening, and I'm happy to take any questions at this time.
Thanks, Kelsey. Now, just for a change of pace, I'm going to ask a different question first. How did you determine that the study was valuable to patients?
Yeah, so yoga has been well studied in adult cancer survivors and has shown lots of very good benefits. It is less studied in kids, but there's still promising evidence. Most of these studies are single group designed, but there's still promising evidence for these populations. As well, there's been studies that have looked at qualitative outcomes, and all of the results have been very positive from patients and families.
Thank you. And my typical question, how has the pandemic impacted your research?
Yeah, so initially we were going to implement an in-hospital yoga trial at Alberta Children's Hospital. And my study was going to be adding a qualitative piece to that and looking at patients and family experiences, yoga instructor experiences, and healthcare provider perspectives of the program. But unfortunately, COVID kind of put a wrench in that and stopped recruitment. So we haven't been able to continue on with that. So I was able to transfer my study to be conducted online, doing the systematic review and still doing the virtual interviews with yoga instructors.
Thank you. What do you hope to do with the results?
I hope to present it to, like I said, the key stakeholders, so patients and families and yoga instructors. And then I hope that this can be used to design and optimize future programs and to help build this evidence to eventually help to contribute to having yoga as part of standard of care for these populations.
All right, that's fantastic.
That's all the questions.
Oh, sorry, go ahead, Christine.
No, it's okay. I was just saying, I think that covered all of the questions.
All right, perfect. Thank you so much, Kelsey. That was a wonderful presentation. And we'll move on to our last presenter today, Ryan Mallard, who is doing a PhD in health services research at the University of Calgary. And Ryan is presenting today on implementing the relational care model of primary healthcare service delivery. Oops, one sec here. Implementing the relational care model of primary healthcare service delivery in a multidisciplinary healthcare setting. So Ryan, take it away.
Thank you very much for the introduction. So my name is Ryan Mallard, and you just got the title of my presentation. So a little bit of background. My PhD work was inspired by a community-based intervention that was first implemented in Lethbridge, Alberta. It started around 6 years ago, and I've been a research associate on that project for the last 6 years. So the project was called Innovative Models Promoting Access to Care Transformation, or IMPACT. The goal of IMPACT was to enhance access to primary healthcare for vulnerable populations. Using a participatory action research approach, we brought together stakeholders and partners, including patients and community members, to design and implement an innovative intervention. The result was a pop-up model of service delivery that brought together and co-located service providers in an easy-to-reach location in an underserved region of Lethbridge. If you know Lethbridge, it was North Lethbridge. So Christine, my next note is for you. Initially, my project was going to be replicating the pop-up model of care in a different location. However, COVID has made it difficult to co-locate a bunch of service providers and invite a bunch of people to come and access services. So I was challenged by my supervisors to think about what interested me most about the pop-up model and how I could develop a project that kept the spirit of the pop-ups, but was appropriate for this new COVID reality. I began to think about what the key ingredients of the pop-up were. We used the Levesque et al. Framework to understand access. We did not want to simply think about access as service provision. The Levesque et al. Framework conceptualizes access as having a supply side and a demand side. The supply side can be thought of as health services and service providers, and the demand side can be thought of as people needing the care. So a couple examples of when we were designing the pop-up model in Lethbridge, our partners said that any intervention had to be approachable, engaging, and easy to reach, especially for people who are underserved by and struggle to connect with healthcare services. So these domains of access can be thought of as the key ingredients for enhancing access to care for people who are underserved by and struggle to connect with services. So an example of approachability would be the picture on the left, where very plain language signage was used. The text is hard to make out. And the service provider brought a bunch of interactive examples. She was in nutrition services. And an example of patients or people needing care wanting to engage with it would be approaching a table that has a bunch of cool plastic food on it, or playing a game or something. An ability to reach would maybe be an example of providing a taxi voucher for people that need to get to the services. So when we put these domains of access in a handy Venn diagram, we get what we're calling the relational care model. The model prioritizes relationships formed between service providers and the people needing care, and also ensures that people get to the care they need. So as part of my work, we will work with interested PCNs to implement the relational care model in their clinics. Early conversations suggest that PCNs say they provide relational care, but the data they routinely collect may not demonstrate this. After working with service providers, we will use routinely collected data to demonstrate the effectiveness of the model using a pre-post approach. We will also conduct interviews with service providers and patients accessing care. So implementation will also take a very principled approach that inspired the pop-up. So that framework there, or that model, is from King et al. And we will ensure that we work together differently, meet people where they are, prioritize relationships, and ensure that everybody gets the care they need. So applying the relational care model in PCNs will enhance access to care for patients. We will also have patients as partners in this work, because the model being implemented is in a very different context than where it was first implemented. So we will have to ensure that clinicians are partners and patients are partners, so the model fits the needs of patients and the clinics interested in adopting the model. And thank you. That's it for me, and I'm gladly take any questions.
Well, when you answer my questions as part of your presentation, what am I supposed to ask?
I'm sorry.
No, just kidding.
So it did really change, because of course we couldn't just implement the pop-up because COVID has made that maybe not a possibility for now. So I had to rethink what the fundamentals of the pop-up model were. What did we do that enhanced access to patient care, and how that can be translated into this new world we're living in.
Thanks, Ryan. What was the inspiration for your research, or where did your research, where did it come from, I suppose?
So it does come from the pop-up model that I've been helping implement for the last 6 years. And it was really about developing an innovative intervention that enhances access to care. So not just service provision, but how can care be provided better? And the data that we got from Lethbridge really suggests that this can be adopted elsewhere and translated to different contexts. And it's an emerging, there are some emerging principles from the work in Lethbridge that should be shared in other settings. Does that answer your question?
Yes, it does. Thank you. There weren't any other questions unless you had any, Kelly?
No, none have come into me. So I guess I will say, Ryan, thank you so much for a great presentation. Good job.
Thank you.
And we still have a few minutes left in this session. So I wanted to ask if there were any more general questions or questions you didn't get to ask any of the presenters today. Please feel free to type your question in the chat, either here in Zoom or over in the Whova app, or if you wanted to even just raise your hand, we can unmute your mic and have you ask your question. I don't see any questions coming through here or any hands being raised. Christine, have you received any questions in the Whova app?
No, I haven't.
Okay, well, I will remind everyone that in the Whova app, there is still an opportunity to post questions and follow up to the presentations in the Q&A box in Whova, if you have any other questions for the presenters. But for now, I will just say thank you to everyone, to all our speakers, and to all of you who attended. Let me just turn my video back on so you're not just hearing my voice. As I said, please continue to post questions or comments for the students in Whova, and the recording of the session will be available to watch in Whova within about 24 hours. And I'd also like to announce for those of you attending the Virtual Institute that our Twitter contest for favorite poster and video abstract opens today. So please be sure to vote for your favorite, and the winners will be announced after our closing plenary on November 20th. So thank you all for coming today and for the great questions for the students. And be sure to join us next week on Tuesday at the same time for the other half of our student awardees. Thank you very much. Have a great day.